Hello, my name is Tom Beach. Welcome to the World Parkinson Coalition Virtual Congress. I'm going to talk to you about peripheral biopsy for biomarkers in Parkinson's disease. But first of all, I'm going to talk about biomarker studies in general. Not all biomarker studies are equally rigorous. Many are critically inadequate, in fact. Initial publications often overestimate accuracy. Independent replication is essential. Results must have a wide range of values and/or an adequate number of controls as well as cases. For PD, both early and late-stage disease cases should be assessed. For case control studies, appropriate disease controls are essential, as well as normal controls. For example, progressive supranuclear palsy as a disease control for PD. In terms of rigor, single-center studies are the least rigorous. Multi-center studies are more rigorous. Blinding, of course, increases the rigor, and if blinding can be done by a third party who is unbiased, that's even better. Of course, FDA and EMA monitored studies are most rigorous. For subjective biomarkers, such as those that use imaging or histology, judge training is essential. It's important to consider the gold standard. For most PD biomarker studies, the clinical diagnosis of PD is used as the gold standard. However, at early stage PD, the clinical diagnosis of Parkinson's disease is only 60 to 65% accurate. So it's really best to add, if you're using the clinical diagnosis as your gold standard, an established biomarker such as DAT scan. Of course, autopsy neuropathology is the best gold standard. I'm going to talk to you about a series of studies we did with the sponsorship of the Michael J. Fox Foundation. These were between 2007 and 2020. The first study was a whole body autopsy survey for synuclein pathology in peripheral organs. We wanted to use the best method available at the time, so we invited 8 expert labs from around the world to each stain a standard set of slides with their best method. The blue arrow shows the best method, which was developed by Dr. Charles White at University of Texas, Dallas Southwestern. As you can see, there is a lot more pathology in this slide than in the 3 other methods shown. The little red dots are all presynaptic terminals filled with pathologic synuclein. The red, larger balls are Lewy body-like inclusions. The best method turned out to be the LB509 antibody to unmodified synuclein with a pretreatment of proteinase K to digest normal synuclein. Normal synuclein is extremely abundant in the nervous system, and it's important to distinguish between it and pathological synuclein. We also tested FFPE sections against thick free-floating sections and found them equivalent. We adapted the method for our whole body autopsy survey, but substituted an antibody for p-serine 129 synuclein, which itself is specific for synuclein pathology. In 2010, we then published the whole body autopsy survey. What we found primarily was that peripheral synuclein pathology is only found in cases that also had brain synuclein pathology. The sensitivity was best in the submandibular gland, meaning that both the prevalence and density of synuclein pathology was greatest in the submandibular gland. We found there was a proximal distal gradient for GI tract synuclein pathology, as had been reported by others before us. This means that submandibular gland and esophagus had the highest prevalence and density of synuclein pathology, followed by stomach, small bowel, and large bowel. We suggested at that time that biopsy of submandibular gland might be useful for Parkinson's and dementia with Lewy bodies. The top figure on the right shows an autopsy section of submandibular gland stained with our method for pathological synuclein. The black, enlarged, distorted fibers shown here is indicative of synuclein pathology. In 2014-2016, we went on to do submandibular gland needle biopsy studies. These were done in the office by an ENT surgeon. Briefly, 74% of the 31 cases studied, both early and late stage cases, were positive versus 20% of 10 normal controls. We're following those 2 positive normal controls to see if they might represent prodromal Lewy body disease. The yellow area highlights the name of my collaborator through all these studies, Dr. Charles Adler of the Arizona Mayo Clinic. The bottom frame shows some black synuclein fibers containing rather pathological alpha-synuclein in a biopsy of submandibular gland. In 2016, we went on to do a multi-center blinded study of colon biopsy for PD. This was in response to conflicting publications about the accuracy of colon biopsy for synuclein pathology for PD. We invited four labs participated rather, that of Pascal Derkinderen in France, David Munoz in Canada, Jeff Cordauer in the United States, and our own lab in Phoenix. The Derkinderen lab supplied archival FFPE colon biopsies from 9 PD and 3 controls. We used 4 IHC methods and 4 judges, 1 each from the 4 labs. Disappointingly, no method was specific. The area under the curve averaged only 0.61. We concluded there was possibly not enough submucosa in the biopsies. There's very little innervation in the mucosa. The submucosa and muscular layers in the bowel contain most of the innervation. And we concluded there was probably not enough submucosa in these biopsies. So we repeated the study in autopsy colon. Autopsy colon has 3 layers, and we also had the neuropathology gold standard PD diagnosis. The same 4 labs tested 7 IHC methods on colon from 5 PD and 5 controls. Only 2 of the 4 judges had acceptable accuracy, but those 2 were very accurate. So that with those 2 judges, one of the 7 IHC methods had 80% overall accuracy and another had 100% accuracy. Pictures on the right show in the top panel brown synuclein fibers using one method in the mucosa. The middle picture shows black synuclein pathology containing fibers in a submucosal ganglion. And the picture on the bottom shows black synuclein pathology containing fibers in a ganglion in the muscular layer. 2017 through 2020, we went on to take part in the Systemic Synuclein Sampling Study, or S4. This was a multi-center study with 60 PD cases and 20 controls, in which each subject had biopsies of colon, skin, and submandibular gland. We selected the IHC method in the preliminary study, and it was the 5C12 antibody to unmodified synuclein with a protease pretreatment. We did extensive training with 3 histology judges who, during the study, did separate blinded reads. Then we all came together to do consensus reads on any discrepant calls. The results were highly specific, greater than 90% for all regions. There was only 1 false positive subject. The sensitivity, however, was disappointing, only 56% for submandibular gland, 24% skin, and negligible for colon. Most of the PD cases were early. 20 were less than 2 years, and 40 were less than 5 years. And in fact, we looked at this late group alone, submandibular gland sensitivity was actually not too bad at 78%. We concluded again that colon biopsies have insufficient submucosa and lack sufficient innervation for this type of biomarker study. Other groups have claimed higher sensitivity for skin, but are less rigorous than S4. The top panel shows brown synuclein fibers in the mucosa of the colon. The middle fiber shows a brown synuclein fiber adjacent to sweat glands in the skin, and the bottom panel shows brown synuclein fibers in the submandibular gland. Now, though, we consider that maybe immunohistochemistry is obsolete for this kind of study, as we are getting much better sensitivity of seeding assays in preliminary studies. Seeding assays include PMCA and RT-QuIC. We've been working with the Kanthasamy lab at Iowa State on these, and so far have published 2 papers, one using autopsy submandibular gland and one using autopsy skin. In both of these, sensitivity and specificity were over 90%. Also, the aggregation rate in the skin study correlated with brain Lewy body stage, UPDRS motor score, and disease duration. We've also been working with the Zoo Lab at Case Western, and they have similar results, over 90% sensitivity and specificity in autopsy skin from PDN control cases. We think that there is potential for peripheral biopsy to be used not only for diagnosis, but for progression tracking. And we have published the only study that I know of which looks at this. We found a 4-fold submandibular gland synuclein pathology density increase with a second biopsy at 4 years using immunohistochemistry. And we plan over the next 4 years to do RT-QuIC on 2 time point skin biopsies in 120 subjects. Thank you.